Welcome to our adrenal pathology lecture, part 1 of 2, diffuse adrenal disease for the sonographer. This lecture will cover Addison disease, Cushing syndrome, and Conn syndrome. Let us start with Addison disease. Addison disease comes with multiple alternative names, including primary adrenocortical insufficiency and chronic primary hypofunction. These two names should clue you in that the function of the adrenal glands is depressed. The adrenal gland fails to produce enough cortisol and aldosterone. The cause of Addison disease can be unknown, brought on by autoimmune diseases, or in response to an infection like tuberculosis. A patient with Addison disease will show signs of low blood pressure, weakness, loss of appetite, bronzing of the skin, elevated LFTs, high levels of potassium, low levels of sodium, and increased ACTH. The increase in the ACTH is because the pituitary gland is trying to get the adrenal gland to release its hormones, but it doesn't. So the pituitary keeps pumping out the ACTH and hopes to get some sort of hormonal feedback from the adrenal gland. A good trick to remember that Addison's disease is the excess ACTH. You can think of Addison as adding ACTH, and they both start with the letter A. On ultrasound, the adrenal glands may be seen as they will become enlarged during the acute phase, but as the disease progresses, the adrenal gland will begin to become smaller and calcify, thus rendering the glands basically ineffective at releasing any hormone. Next up, we have Cushing disease. Cushing syndrome is the result of a tumor on the adrenal gland called an adrenal adenoma. So Cushing syndrome, this tumor is going to release excessive amounts of the hormone cortisol. A very similar disease with similar pathophysiology is Cushing disease. This is due to a tumor within the pituitary gland that causes too much ACTH to be released, thus telling the adrenal gland to release more cortisol. So Cushing syndrome is a tumor on the adrenal gland. Cushing disease is a tumor in the pituitary gland. The adrenal adenoma releases its own excessive amount of cortisol in Cushing syndrome, where in Cushing disease, the tumor in the pituitary gland causes the pituitary gland to release too much of that ACTH, which then acts on the adrenal gland and tells it to release too much cortisol. Cortisol has many functions in the body, such as controlling blood sugar levels, regulating metabolism, help reducing inflammation, and even assists with memory formulation. It also has a controlling effect on the salt and water balance and helps control blood pressure. The symptoms that we see then all have to do with too much of that cortisol being in the body. So what we see with excessive cortisol causes many symptoms, including obesity, thinning arms and legs, high blood pressure, hirsutism, which is excessive hair, high blood sugar, severe fatigue, poor wound healing, a buffalo hump, moon-shaped face, and red or purple striae over the abdomen and thighs. You can think of Cushing syndrome as adding extra cushion to the body with the extra fat. On ultrasound, we may or may not be able to see an adrenal tumor. The last adrenal disease is Conn syndrome. Conn syndrome is also known as hyperaldosteronism, which tells us that the Conn syndrome is identified by the presence of too much aldosterone in the body. This disease is commonly caused by a tumor in the adrenal gland that releases hormone without talking to the rest of the body first. Aldosterone also has many jobs in the body. It causes an increase in salt and water reabsorption, so the kidneys can improve the blood volume in the body, therefore restoring blood pressure. So because aldosterone affects the way the body absorbs and releases salt and water, patients are going to show signs of high blood pressure, excessive thirst, excessive urination, high salt levels, low potassium levels, which can lead to muscle cramps. On ultrasound again, we may or may not be able to see the adrenal tumor. So I think this is a good chart to help us see how the diseases are similar and different from one another. Focus on the chart and the key symptoms that are related to each disease and how the cortisol, aldosterone, and ACTH levels are in the body. Next up, we have part 2, focal adrenal pathology, where we will look at focal benign and malignant tumors of the adrenal glands.